Hello everyone, this is a knee joint of a young individual who has twisted his left knee joint and injured his ACL ligament as well as the posterior horn of the lateral meniscus. On diagnostic arthroscopy, you can see that I am seeing from the anterolateral portal and there is complete tear of the ACL ligament from its femoral attachment. So now I am going to remove the tibial stump of the ACL and you can see that I am gradually removing the remnant of the ACL in order to visualize the ACL tibial and femoral footprint. ACL is one of the most commonly injured ligament in the body and it usually happens because of the sports injury or road traffic accident. Whenever there is anterior translation of the tibia or femur in flex position, there is high chances of ACL injury. Many times meniscus injuries are also associated with the ACL injury, so we need to look for that carefully so that we don't miss such injuries. And you can see now I am reaching the ACL femoral stump and I am debriding it with the arthroscopic shaver. So this is the final picture after debridement of the remnant of the ACL, and now we are going to look into the medial compartment, and you can see in the medial compartment the medial meniscus, the tibia and the femoral condyle looks quite normal. And as we go in the lateral compartment, there is a tear involving the posterior horn of the lateral meniscus, which is around 2 centimeter in dimension, and it is in the red white zone. So we are going to repair this tear because in young individuals such tears should be repaired, and this kind of tears have good healing potential because they are in vascular zone. And in young age, when we repair the meniscus, we are not removing any part of the meniscus and we are preserving the meniscus, which is going to improve the stress distribution in the knee joint because meniscus is the structure which provides congruent concavo-convex configuration. So as you can see, I have changed my viewing portal from the anterolateral to anteromedial portal, and now I have inserted my all inside device from the anterolateral portal. And after taking first bite from the superior capsule and the second bite from the substance of the meniscus, I am going to pull the thread in order to tighten the knot, and this reduces the tear quite nicely. And this is the medial most knot that we are going to take. So we are done with our first stitch, and now we are going to proceed towards another stitch which should be around half centimeter away from the first stitch. You can see I am trying to negotiate my all inside device superior to the meniscus, and once I pierce the posterior capsule, I am going to deploy my first implant. We should be very careful because there are neurovascular structures right posterior to the capsule, so we should keep the needle length to less than 20, and we should just pierce as much as it's required to pierce the capsule. And now I have passed my second implant through the substance of the meniscus and I have tightened the knot, and this completes the repair of the posterior horn of the lateral meniscus. You can see that the meniscus is nicely reduced and it's quite stable, and this is going to heal very nicely in this case because it's a young patient and the tear is in the red white zone. So whenever possible in young individual, always try to preserve the meniscus when meniscus are torn because this is going to affect the joint arthritis in long term, and we should always try to repair the meniscus in its anatomical position. So now we are shifting towards ACL reconstruction. You can see that I am viewing from the anterolateral portal. I have inserted my femoral femur which is 7 mm offset from the anteromedial portal, and I have drilled my guide wire through the lateral femoral condyle, and now I am going to drill over the guide wire with the endo button drill bit. Provisional length of our tunnel is around 40 millimeter. Now I'm going to introduce depth gauge from the anteromedial portal, and you can see that the length of our tunnel is 42 millimeter. So now I'm going to insert the guide wire through the lateral femoral condyle and drill with the 9 millimeter femoral drill bit because the diameter of our graft at the femoral end is 9 millimeter, and we are going to drill up to mark of 30 millimeter because we intend to keep 20 millimeter of graft inside the tunnel, and 10 millimeter is the distance which we keep to facilitate the flipping of the endo button. So this is the view of the femoral ACL tunnel as seen from the anteromedial portal. You can see that it's in its anatomical footprint. So this is a good femoral ACL tunnel, and they should give good stability for this patient after ACL reconstruction. So now I've used my ACL tibial jig to drill the guide wire through the tibial ACL footprint, which is around half centimeter medial and posterior to the anterior horn of the lateral meniscus. And on top of this guide wire I am going to drill with the 10 millimeter drill bit, because the diameter of our graft at the tibial end is 10 millimeter. So this is the tibial tunnel as seen with the arthroscope, and now we have passed the graft and we have flipped the button and we have fixed the graft at the tibial end with interference screw, and this is the final picture of the ACL graft as seen through the anterolateral portal. You can see that it's quite robust and strong, and it is in its anatomical location. This is going to provide good rotational as well as anterior stability to the knee joint of this patient. We are going to keep this patient non-weight bearing for 1 month duration, and we are going to allow 90 degree of knee bending by 1 month, and by 6 weeks he should have full knee bending. Thank you.